You're listening to the Yoga Medicine Podcast. I'm your host, Tiffany Cruikshank. Our podcast brings you information and resources to enhance the therapeutic effects of your practice based on a deeper understanding of anatomy, physiology, and the integration of modern science and research with traditional practices and experiences. Join me and my co-hosts, Rachel Land and Katja Barch, as we dive into all things yoga, research, and wellness. The content of this podcast is not medical advice and is not meant to replace medical care. Please consult your healthcare provider to determine what is best for your unique healthcare needs. Welcome back, everyone. We're excited to be back here, and I'm excited to have Katja here with me again because we are talking about the fascia, her particular area of study. I'm really excited to be talking with you, especially because of not only all of your work and research, but those of you who don't know, Katja has the huge, amazing opportunity to be overseen in her research by Dr. Robert Schleip. I often think of him as like the godfather of fascia research. And gosh, he has so much, I'm sure, wisdom to impart and great things to be working with. So today we're talking about a really interesting, cutting edge new topic, looking at fascia and pain. And I think it's a really interesting one to look at because we're starting to bring to light more and more just how relevant this tissue is when we're looking at pain and just how important it is to consider when we're looking at pain. And as we all know, most of us experience pain in some form in our lives. Hopefully it's brief and passing. But I think we all have some experiences. So we're going to be talking more on this, more on why it's important, on how it happens, and on, of course, ways that you could also potentially intervene. So I'm excited to kick it off. Katja, do you want to talk about a little bit of the background on that for us? Or maybe what brought you, because I know this was partly your idea, your enthusiasm behind it.
Yeah, I'm very, very enthusiastic about anything that relates the nervous system to fascia. And I think that interconnection is really so cool because it explains, or to me at least, explains many things, how the body and the mind and everything in between relates. And one specific aspect of this is fascia's role in pain. And there's a lot of studies that are recently being published on fascia and pain, that are putting forward new hypotheses, how we can interweave that with our lifestyles, with psychology, but also on an anatomical and physiological level. And I'm really excited to chat about all of this with you today.
I know. I love, you sent me a bunch of research that we kind of dig through before the show, and I was digging through it all, and it really is incredible how much information there is now. I mean, obviously there's still so much to learn, but there really are so many very rich, robust studies to look at to kind of see the importance of this. And, I think one thing that's important to consider is, I think one thing that comes to mind for me first off is like, why is it important to differentiate pain in the fascia versus the muscle? I know as yoga teachers and body workers, it's almost impossible to really dissect and separate, because when we're pressing on one, we're pressing on the other without a scalpel, without opening someone up, which I don't recommend. We really can't be specific. However, I think what's really interesting is that what it does is it starts to bring to light the importance of this tissue, of the fascia. It starts to bring more attention to it, this tissue that we used to just throw away. And I know still happens in dissections in medical school where, the fascia is discarded. And as we start to learn more about it, we start to learn some of the nuances. And as we then start to learn more about the fascia, we might learn different ways to target it or be specific to it, as we've kind of alluded to in some of the other episodes. And I'm sure we'll talk about more. And then, of course, there's the medical side, that the medical interventions can be more targeted, potentially too. But I also just want to keep in mind that it is all connected. However, as we start to learn more about this tissue, I think we start to learn more about pain, which is in many ways a big mystery box. We are starting to learn so much more about pain in general, the research around pain has kind of, I think, exploded a lot in the last decade or two. And so as we start to look at fascia, I think it's a really interesting area to look at. So let's talk about differentiating fascial pain versus other types of pain. Is it possible to differentiate them completely? Can we kind of weed through them and see some differences?
I think the latter is the case. I think we can see some differences. And to me, it's also quite interesting how we know about this. Just to give you a little bit of background information, we know that there is different qualities to pain when that pain comes from your muscle tissue versus when it comes from your fascial tissues, the deep fascia, or when it comes from your superficial fascia or the tissues right under your skin. And how we know this is that there are studies that do inject fluids in those different layers of tissue. So, for instance, into the muscle tissue or into the deep fascia. And sometimes it's only saline that we put in there. And then you ask the person and you measure with certain things how intense their pain is. And you can also ask them how long the pain lasts, and you can find out about how much the pain spreads. And we do know that when we inject those fluids into the deep fascia, that this tissue layer is more painful, the pain lasts longer, and it's also radiating more, so spreading out more. And we do know this about the deep fascia, specifically about the crural fascia, so your lower leg, and also the low back, the thoracolumbar fascia. And then you already kind of hinted towards the quality of that pain. So it's not only the intensity or the length of pain, but also the quality seems to be different. So again, when you inject stuff into muscle tissue, the person may respond that the pain is quite mild. But if you inject something into the deep fascia and also into the superficial fascia, people will respond quite differently. They will tell you that the pain is burning and stinging, or maybe even horrible or exhausting. So the descriptors of that pain are so much more immediate and intense. So we can really say that the deep fascia particularly is a prime candidate for pain, and the quality seems to be quite intense to compared to, for instance, the muscle. Now, one thing I want to make clear right from the start: this is not something how you can diagnose something. So you cannot say, "Oh, my pain is horrible and stinging. That must be pain from the fascia." That's not the case. That's not possible. But it's pointing towards the fact that the fascia can be a really prime candidate for pain.
Hmm. I remember hearing about this research too in I think it was a fascia conference recently. Was it Carla Stecco or was it Helen Longving? It was
Yeah,
Stecco.
Carla Stecco is talking
It was
a lot
Longving.
about this, and she has done amazing talks and webinars on this. We will also put some of that in the show notes, and I'm drawing from her work and from her findings, because she conceptualizes this quite beautifully and, to me, quite easily to remember. So if you want to find out about her, she's a bit of a rock star in the fascia
She
research
is.
world from Italy. Yeah, she is.
I love her.
And we will hear about a couple of her studies today as well.
Yeah, I mean, that kind of blew my mind hearing about that. I mean, first, just being able to differentiate between the layers was pretty mind-blowing for me. Um, and then there's this idea of delayed onset muscle soreness too, as a different kind of pain. I know that is oftentimes, well, is more in the present day due to our newer research understanding, more thought to be happening in the fascial layers versus the muscle. Is that correct?
Well, what we definitely can say is that, related to the experience of pain, again, the pain threshold seems to be also decreasing more in the fascia than in the muscle underneath, meaning that you feel more of that delayed onset muscle soreness pain in the fascia, or quicker, so to say, or more readily than in the muscle tissues themselves. So from that standpoint, from experiencing the pain, it's kind of the same thing that we described before, specifically in delayed onset muscle soreness as well.
Yeah, and I think, there's so many misconceptions around that delayed onset muscle soreness too. So it's an interesting one as we start to look at where it's actually coming from, as we start to unravel a little bit more information around that. And obviously keep in mind, everyone who's listening, that pain is a very complex thing. I just want to kind of draw some attention to the fact that we're talking about pain as this nociception that's happening within the tissues, more of a mechanical pain. But keep in mind, all of the pain that we experience is also interpreted in the brain. So it's always being filtered against all of our past experiences, our emotional state, both at the time of experiencing that as well as maybe past experiences with similar sensations. And so just keep in mind that pain is a lot more complex and we talk about pain. But as we look at these nociceptors in the tissues and look at this mechanical kind of alterations, I think we can find some really interesting information in the fascia. So, was there anything else you wanted to talk about with the quality of the pain associated with the fascia, or do you want to move on to the next part?
I think we can move on to the next part. One thing maybe we want to close with there is some of you might be health professionals, manual therapists, and so on. So some people, Carla Stecko, for instance, says that when you're touching someone, when you're working on someone, that quality of pain that we mentioned, that stinging sensation, might be something that you experience with your clients as well. So they might report kind of like that cutting knife kind of sensation that might be, as mentioned before, an indicator that you're more working on a deeper fascial layer. But as you already mentioned, Tiffany, we're working on all the layers, so it's hard to differentiate on a clinical level. Nevertheless, you can still listen closely to what your patient or client is telling you, and I think that's still something we can keep in mind.
It's interesting too because as an acupuncturist, I always really associated that stinging pain that people get. And those of you who've ever had acupuncture, there's no way to avoid it, but there's always maybe probably one needle in any session that's kind of stinging. Maybe not, maybe one every couple sessions, but usually there's one area or an area or two that are kind of stinging. And I've always associated that with being near a blood vessel. And so as an acupuncturist, if they're okay with it, usually it'll calm down. If I can get the needle into where I want it to be, it'll calm down and I'll just leave it. However, if I'm just barely in and I'm not where I need to be, I'll usually take it out and redo it. And oftentimes, it's fine the next time. So it's interesting that maybe there is some alterations. I don't think we know enough yet at this point to really say, especially as it relates to acupuncture, which is a little different because I am now inserting something sharp into the body. um, but I just think it's an interesting one that could also, our understanding of these changes can also bleed over into a lot of different areas of medicine as well. So
For
when
sure.
we look at fascia as a source of pain, I think it's really interesting to break it down into some different changes that can cause that. So when we look at the different things that lead to these alterations in the fascia, what we can see is kind of the larger, more macroscopic. I think Carla Stecco, I think, was the first person who was she the one who used these categories, and I loved it. I heard it on one of her webinar or something that she did, and I just thought it was brilliant to kind of break it down into these categories of macroscopic changes in the fascia that contribute to pain versus microscopic changes, the things that we can't see. And then also changes within the tension system that can also be a really important contributing factor, all of which I think are really interesting. So let's start by talking about the macroscopic changes. What are some of the macroscopic changes that can happen in the fascia that can contribute to pain or the fascia as a pain generator?
Yeah, as you said, it's oftentimes something we can see or at least palpate. So scars would be a typical example. Scars can be quite obvious from looking at them. So they can be quite big or quite prominent at the surface. They can be quite prominent underneath. So you can even have like a superficial scar that doesn't show, but underneath it might be like a really deep and intense scar in the fascial tissue that may cause some pain in that fascial tissues. So that's one big thing. Edema, so fluids in the fascial tissues might be one. Any kind of fascial thickening, so fibrosis, those would be a couple of the obvious ones. And we can either look at them, we can palpate them, or ultrasound imaging, stuff like that can also make that visible. So that's kind of like the bigger changes that are more obvious in the tissues.
I've worked a lot with scar tissue, especially women who've had C-sections, and some as an acupuncturist, some more with the myofascial work. And I find actually the combination of the two is so helpful, because with the acupuncture I can get into a little different layer and I can shoot electricity through it. But I think what's interesting about the scar tissue is, and having done a lot of dissections too, you know, you can actually see the scar tissue going through the layers when someone's had an incision, a surgical incision, in particular. And so there are some scars, you know, that are very apparent, versus I think we tend to use the term scar tissue pretty loosely as kind of more adhesions or thickening or fibrosis. Or often I'll compare it to this idea of velcroing between the tissues. But what's interesting is when we have a really significant scar, like a surgical scar, that surgical scar is not going to go away. That's going to be there, and everyone kind of responds to with scar tissue a little bit differently. However, if I can release the adhesions around that scar tissue with manual therapy or with acupuncture, it's pretty mind blowing actually, how helpful it can be, not just to pain, but I've had people with numbness, and even some changes in visceral function as well. So it's I would say probably the smallest category we're going to talk about is the macroscopic changes, but I still think it's a really important one to look at when we look at the changes within the fascial layer.
Definitely. And again, referencing Carla Stecco, when she started out in researching fascia and pain, what she mentioned or thought back then was that those kind of obvious changes in the macroscopic structures would be like the main contributor to pain in the deep fascia. But she does definitely no longer think that. And we're going to talk about microscopic structure changes next, I think. And that's something that's a lot more complex. But she thinks that that's more important or has more contribution to the whole complex of fascia and pain, even though initially that fascinating topic of scars and all what we've discussed up until now have been like a major role, but she wasn't finding that as a clinician and as a medical professional. So that's kind of interesting too.
Well, I think it makes sense because the scars are what we can see and palpate and feel and know. And yet it's such a small percentage of probably the, if you're a healthcare provider, the patients you work with, or yoga teacher, the students or clients you work with, or body worker, like, you know, I think it's a, for all of us, it's probably, for any clinician, it's probably a very small percentage of the people that you're working with who have pain. So I would definitely feel a connection to what she's saying there for sure. So let's talk about the
Yeah.
microscopic changes. Where do you want to start with the microscopic changes? Because we've got a few.
Mm. Yeah, there's one big topic I think that we can relate well to in our yoga realm. It's that slide and glide between the layers. And if you have practiced some sort of myofascial release, if you have been on yoga medicine online or in any of Tiffany's training, you will have heard about that slide and glide, I'm quite sure. So when we see someone with pain, particularly chronic pain, that slide and glide between our tissue layers seems to be impaired, and that is something that we cannot see at first sight. But there is a couple of studies that are also quite prominent in the fascia world that have shown that in low back pain, chronic low back pain, but also in chronic neck pain, this slide and glide between the fascial tissue layers is decreased. We call that shear strain. So the shear strain or slide and glide between the layers got worse in people with low back pain or with chronic neck pain. And that seems to be one contributor or one cause of chronic of pain in the deep fascia. And then we can also relate that to movement. So we also have some studies that bring together the idea of decreased slide and glide and immobilization, for instance, after injury. And I'm sure, Tiffany, you talk about this in some of your trainings as well. Um, Another name we may want to throw into the mix here is Helen Langeva and her research group. So some of the stuff I've just been talking about comes from her group, some from Carla Stecco's group, and then one really cool series of studies from Helen Langeva's group relates to that idea of moving less after an injury and then having even less slide and glide if you have an injury and don't move after an injury. I have to say, though, that these findings come from pigs. And that makes sense because pigs have quite similar structure of their thoracolumbar fascia, how the thoracolumbar fascia is built up like we humans. So some of those studies are human studies and some of them are animal studies. But we do know that if you have an injury and don't move, that slide and glide gets even worse or decreases even more.
And we see this a lot. I mean, just in the past 10 years, I've been practicing for, I think maybe 18 years now and seeing patients. And, for the first maybe half of that, post-surgical patients, were encouraged to be very careful and not move around. And just in the past 10 years, I feel like it's changed so much with surgeons really trying to get people up and moving right away, which, as we learn more about the fascia, it makes perfect sense. This is one of those examples too of maintaining that gliding, and one of, I think, the many reasons why we hear so much about how bad being well how all of the negative effects of being sedentary, of just getting up every so often, whether that's just for a few minutes. And I think it's also one of the reasons why just going to like a slow flow class where you're not pushing really hard, you're not necessarily holding any deep stretches, you're not going deep into your range of motion, but there's just this kind of fluid, flowing movement, this kind of whole body movement, why so many people love it and feel great afterwards. It's not necessarily specific to an injury or an issue, but I think a lot of people tend to feel that effect of from a very what might seem like a very simple practice of feeling really good afterwards. Now, part of that is that gliding. Part of that is also potentially the thixotropic quality of the hyaluronic acid within those gliding layers that we're looking at, and what that means. Basically, that thixotropic title basically just means that it becomes more, I always like to think of it more like sludge, more viscous and dense as we become more sedentary. And as we move, or if we were to shake that fluid up, it becomes more fluid. And so just with this simple whole body movement, we literally have more fluidity within the tissues. And where that hyaluronic acid becomes most important and probably most dense is in those gliding layers where we need that movement. The body's brilliant, right? It's designed, all those fasciocytes creating hyaluronic acid are there secreting it so that it is able to glide freely. And all we have to do potentially is keep using it, keep moving. So I love it when there's these brilliant things built into the body. And I love it too because it reminds us that, sometimes we go to exercise or do yoga and we feel like we kind of have to beat ourselves up, or we have to achieve something, or we need to get to a certain range of motion, or we need to work hard or sweat or do something specific. But really this kind of gentle, fluid, flowy practice has a very valuable place in our repertoire and can be very important for a lot of reasons.
Definitely.
So,
And you said it beautifully. It can be subtle, it can be slow, but movement, as you also mentioned, has just gained so much more importance also in the medical realm after injuries. And I love that. It's one of those pieces where knowledge about fascia is just that puzzle piece that kind of connects what we as movement lovers have been talking about or have been feeling in our bodies forever. And that's kind of like that puzzle piece that makes the picture so much brighter or more colorful as we understand the whole picture better.
It is all intuitively built into us for the most part. So many of the things that keep us healthy and resilient, and I love that. Anything else you want to say about the gliding as a form of microscopic changes that can contribute to pain?
No, not really. I think we really covered that the slide and glide can be decreased, and we should work on the slide and glide in order to work on our pain or not even come into pain. But it's only one part of the microscopic changes. So another really big one is the innervation of the fascia. So how many nerve endings or how many nerves we have, how dense the fascia is, therefore innervated, and the type of innervation that we can see in people with pain. I think that's another really big topic that I'd like to cover.
Great. Let's go. Let's go there.
Yeah,
Take it
let's
away.
go. I want to throw out another name or another research group because sometimes you can just, go there and look these people up and find really interesting stuff. And if you're listening to this a little bit down the line, there might have been even newer studies from those groups. So one of them is from Heidelberg here in Germany, and it's around Siegfried Menze, and they are doing great research when it comes to the innervation of fascia. So what types of nerves and nerve endings we do find in the fascia. And they have found various things related to pain. I'd like to dig into one study that I love from 2019. So they looked at the thoracolumbar fascia. Low back pain is everywhere around the globe. And the thoracolumbar fascia, we know, is one contributor to that. And they did one thing, for instance, they looked what kind of nerve endings, what kind of receptors we do find in the thoracolumbar fascia. And interestingly, and if you've listened along in our episode on fascia as a sensory organ, you may have heard this already. They did not find like those typical mechanoreceptors, the Ruffinis and the Paccinis and all of these in the thoracolumbar fascia, but they found free nerve endings. And if you've never heard about free nerve endings, again, go back to that other episode. But free nerve endings have various jobs. So they are very talented. They can do multiple things. They respond to different types of input. And they can respond to mechanical input, but also, and many of them do, to pain. So we call them nociceptive fibers. And the fact that there are so many free nerve endings in the thoracolumbar fascia, but none of the other mechanoreceptors, points to the fact that the thoracolumbar fascia holds a role in pain, which I think is something that many people with chronic low back pain will happily, will happily confirm. So that's interesting. And also they found many sympathetic nerves, so nerve fibers that relate to the sympathetic nervous system. And that's interesting again, because again, people with chronic low back pain, they will probably also confirm that when they are under psychologic stress, their pain is more intense or they have more pain. And that could be related to that increased number or high number of sympathetic fibers in the thoracolumbar fascia. So I think those two things are something that is already very interesting, and that's not only in people with low back pain, but also in healthy humans or healthy subjects.
It is really interesting, and I can't wait to like fast forward 10 years and until we find like what different type of receptors are in different parts of the connective tissue and fascia, because I know that it's kind of just in its infancy now. We know a lot about the thoracolumbar fascia. It's one area that's been studied probably the more than any other. It's definitely more than any other. We've got a lot of research on that thoracolumbar fascia, and now a little bit on like the retinaculum and some other pieces. But I just can't wait until we have more. Like, imagine a time in 10 years from now where we've kind of mapped out all the different pieces of fascia and all the different functions and innervations. And but it's still really cool at this point too to look at that thoracolumbar fascia and learn so much about it, just from just at this point too. So, what about too? I think you have a study on here too about the increase in how the innervation changes with pain too.
Yeah, so particularly in inflammation. So, say you have an injury and the tissue becomes inflamed. We do know that during inflammation, certain substances are being released, so called growth factors. And those growth factors can lead to the growth of new nerves, particularly new nociceptors, new free nerve endings that respond to pain. And usually, when the inflammation is over, those growth factors kind of go away, and the number of those nerve fibers also goes down again. So, that's the normal course of things. After inflammation, the tissue has its, let's say, normal number of nerve endings again. But sometimes that's not the case. So, sometimes the number of nociceptive nerve endings, nociceptors, stays increased. And that, of course, can then lead to a heightened perception of pain, which can be beneficial, like right after an injury. It makes sense that you're more sensitive. Say you're in that slow flow class and that felt great before, but right after the injury, a certain stretch is still more painful than it used to be. Makes sense. Your body wants to protect itself, wants to protect that injury site. So first, it's really good that we have that protective mechanism,
Mm.
but if that is prolonged, it may not be so beneficial for the body. So we always have to distinguish a little bit between acute inflammation and then the chronic processes, and if some of these things mm, persist and do not help the body out that much anymore.
It's brilliant. The body is brilliant. I feel like,
It's pretty clever.
when you learn about all these things, at first it can be kind of overwhelming, but then you start to realize that it's actually all there for a purpose. Like, pain is this brilliant protective mechanism of the body, which sometimes gets out of whack and needs a little bit of assistance coming back, especially if it's persisting for long periods of time. But um, really, I think to be in awe of that response of the body to be able to upregulate pain in an area that's injured or inflamed as a protection mechanism is, rather than something to be afraid of, is something to, I think, really appreciate in the body. It's like a mother. The body's always protecting us.
Mothering itself.
And
Yeah,
the
pretty
fascia
pretty
too,
cool.
you think of it like, this fascial layer that wraps around every part of us, like this kind of this warm protective hug. That's my vision.
Oh, it's a nice one. It's a nice one. I'll go to bed with this one tonight. Yeah, definitely the fascia. It's also really cool how to see that other body systems kind of weave into that. So another very recent study from 2021 talks about how in inflammation the vascular system and also the lymphatic system plays into that. And we're talking about fascia and pain today, but I think that one's also really fascinating to weave in here, because it's very recent, and it found or talks about the fact that in inflammation, the lymphatic drainage and also the vascular perfusion doesn't work normally or regularly, and then some of those inflammatory substances can accumulate in the interstitium, or you can say in the extracellular matrix. So there we have the link to the fascia again. And with those substances kind of being stuck in the tissues, you have this fast forward loop, or kind of this vicious cycle, maybe even, of an ongoing inflammation, because the nociceptors are being activated all the time. So that's where it kind of like that idea of fluid movement also ties into
Hmm.
the lymphatic system, and is that interplay between the fascial system, the lymphatic system, and your vascular system, which is also really cool that this is being explored more and more these days.
I love that you mentioned this one because I feel like the lymphatics are so underappreciated. And right now, I'm doing a lot of research on lymphatics for a course that we're creating. And, this idea of the lymphatics and its contribution to inflammation is a really important thing. And the more we can help enhance that lymphatic flow through that lymphatic system, the more helpful it is to a lot of things, including inflammation. And this is a really interesting tie in to pain as well. It's very real. And what I love about the lymphatics is that it is this kind of subtle system. And again, it brings our attention back to, for most of us, and when we do, as one example, for most of us, when we do body work or get body work or do self myofascial release, we kind of love what we can feel. We love to go in deeper and break up that scar tissue. But the lymphatics are just right under the skin, really in that superficial fascial layer there between the skin and the muscle for the most part, besides all the deep stuff in the abdominal cavity there. Um, and so when we look at the lymphatics, that really subtle work that we do, again, we start to look at the value of the subtle things. And I think it's helpful because our human nature is to gravitate toward what we can feel and what we can see. And it's a great reminder that those subtle things are so precious and so important, that there really is some scientific value behind them as we start to understand it. And I think for me and my work with the patients and clients that I work with, that education is such a big part of, if nothing more, just prioritizing the work that I do so that I remember how important it is. It's easy, like in a yoga class, you get to something subtle, you're just kind of like, when are we getting to the practice? But as you start to appreciate these nuances, you start to take it in differently. You start to have a different visualization or inner landscape as you kind of approach these things. There's a preciousness to them now. And so I think it's really important to understand a little bit, or it can be helpful to understand a little bit more. So thank you for adding the
Yeah.
lymphatics in there.
Sometimes your underdog can steal the show, right?
Yes. Many times, especially with
Yes,
pain.
definitely. Yeah. So lymphatic system can play a role in this, but what I wanted to bring across is that your actual number of nerves in inflammation goes up, can go up, sometimes doesn't go down again, and that can contribute to pain. And then also sometimes the pain threshold is decreased, maybe because of the increased number of fibers, or maybe just because the threshold is lower. But generally, we can be hypersensitive to pain because of these things. And that is kind of like why the innervation of the fascia can play a role here. And together with the slide and glide, these microscopic changes can really be a big part of the cause of pain in the deep fascia. But it's tricky. It's, again, maybe even like a little underdog kind of thing, because we cannot see these things like the scars. We cannot palpate these things necessarily, maybe the slide and glide, but it's a lot more difficult to understand what's going on as we cannot see it. We may not be able to feel it right away. And it's so hard to understand what's happening and what to do with it. So those microscopic changes are microscopic, but so important.
I love that you mentioned that, because a lot of times when we go over some of these things in our myofascial release course, I often have one or two students who, chime in, who are kind of kind of angry, for lack of a better word, that their doctor hasn't run tests for these things, that they've suffered from pain for so long and their doctor never ran any tests for these things. And I think it's important to note that that as of yet, there are no tests for these things that would be found in a clinical setting. There are things that are being done in the research modalities. So just keep in mind, I mean, I think all healthcare providers, I hope all healthcare providers, we're all doing our best. We're all studying our brains off and trying to learn and keep up with new research. And, I think it's why it is helpful to specialize and have a specialty. However, we also then as patients need to be able to kind of find the right path. And I think it's our job as patients to remember that it's a journey, health and wellness. I mean, obviously life or death is a little more straightforward in the ER, a little more straightforward. But as we navigate health and wellness and persistent pain and other things like that, it's often a journey. There's often several layers, very microscopic things that are difficult to test. And I might need to go to different practitioners to kind of whittle away at the different layers potentially. There's not always one answer. However, I think as this research continues, we might potentially at some point have a way to diagnose these things in a clinical setting. So, just as a side note, because the doctors are working so hard out there, doing their best. One day maybe we'll have some more tools, clinical tools for this.
Yeah, and also keep in mind some of the studies we're mentioning and that we're putting in the show notes are really brand new, like not even 6 or 12 months old. So it's not standard or hasn't been standard knowledge 5 or 10 years ago. So keep that in
Yeah.
mind as well.
Yeah, absolutely. So let's talk about one last one that's really interesting. We talked about the macroscopic, the microscopic changes in the fascia, both contributing to pain. And then I think a really interesting one as it applies to movement therapists is changes in this tension system, this fascial tension system as it contributes to pain as well.
Yeah. So, I mean, tension, when we talk about movement, when we talk about yoga, maybe let's translate it for the sake of grasping it more easily with a stretch. A stretch would create tension in your fascial system potentially. And fascia can also be a pain generator because it can perceive that change in tension, for instance, through a stretch, but also through other alterations of that tension. And it can even sense that change in tension in spots or in places that are far away from where this tension is created. So I myself am a student and graduate from the anatomy trained school. So when you hear us talking here about stretches and feeling something far away from the place of origin, you may go, oh, I heard about some sort of myofascial connections, functional connections across the body, and something happens in your foot or in your leg, and that might have an impact in your neck or in your head or in your back. That's where we are right now. That's what we're talking here. And the interesting thing is that that mechanical change in tension, so a stretch, for instance, can activate certain nerve endings again, the free nerve endings. And if that mechanical tension becomes too high, the free nerve ending does no longer report a change in tension, but it reports pain. So it becomes not a mechanoreceptor, but a nociceptor, and that's quite interesting. And again, going back to the myofascial continuities or myofascial meridians or whatever you want to call them. There is one colleague of mine, and I've had the pleasure to work with him as well, who's Jan Wilke, here also from Germany. And he has been studying myofascial connections, anatomy trains, and others. And a couple of years ago, he was, I think, the first one to look functionally at that connection throughout the whole back body. Anatomy trains language would be superficial backline, but you may also have heard this as a different term or in different terminology. And what they did was they stretched the back of the leg, your gastrocs and the hamstrings, and they did find a change in range of motion in the neck. So that's the positive way around. You stretch something in the leg and you improve your range of motion in the neck. But we can also switch that around and could say that if you have increased tension in the back of your leg, that could lead to more tension or less range of motion in your neck and potentially to pain there. So keep in mind that we have these connections throughout the body, and the fascial system may respond in a complete different place in your body to that change in tension that originates far away from the actual site of pain. And this has been shown also related to the treatment of pain for low back pain or for SI pain. And there's interesting studies where people did treatment far away from the low back or far away from the sacroiliac joint, and still that treatment relieved some of the pain. So those body-wide connections can also contribute to pain as they are building up tension, or can help with pain as we try to relieve some of that tension.
I love that. That's such a great one too. I'm glad that we're doing this one last because um it's such a nice one to end on. And one of the things I love, I mean, I love when systems overlap. And I know for me, some of my favorite points for lower back pain are actually in the calf and headaches too, which kind of lines up with a lot of these other fascial theories that we're looking at. And again, such an interesting one as we kind of start to learn more about the fascial layers and maybe layer it on top of other modalities like acupuncture, acupressure. Um, so you can try it on if you want. Do some calf rolling when you're having lower back pain or neck pain, which is probably the headache connection too. In Chinese medicine, there's points in the calf too that are used a lot for headaches, which who knows? Who knows what they knew back then and why they came up with those acupuncture points? People always ask me that. I'm like, I don't know what they knew back then. You know, they knew something. They figured out something. They were tuned in or had, I don't know. Who knows? But they figured it out and it works. And, you know, we have a lot of experience using them. I've had a lot of positive experience using them. And as a yoga teacher, you know, you've probably also sensed the benefit of using some of these myofascial continuities to work with areas, especially when someone has pain, because a lot of times I often say in our trainings, you know, one of the best things to do when someone's in pain is to go indirect before you go direct. So instead of going straight for that tissue that's irritated, whatever that might be, the neck, the back, the calf, maybe the calf itself, the foot, is working along these continuities so that I can kind of find a way to ease the tissues without going and poking the bear potentially, which, you know, there's a time and a place for working directly, of course. But I find that that nuance of being able to work indirectly for a lot of people can be more helpful in my perspective than working directly on the tissues. So this gives us another lens into that. Yeah. Yeah, and I think there's so much you could say on the tension system, but really, you know, if you're interested, I would dig into some of those resources. Tom Myers is a great one. His anatomy trains and experiment with your body, even just whether it's tight areas. It doesn't have to necessarily be painful, but restricted areas or tight areas, and noticing how interconnected the whole system is from your experience as well. Mhm.
Absolutely. And then that whole that whole body just becomes the focus of your experiment, as you just said. And it's just so interesting, I think, for us as yoga practitioners and as teachers to have that in mind too, that we don't have to nag. Let's say we do a class on the low back, or some a low back pain class or something like that. You don't have to dig around in the low back for the whole class, but it gives you a bit of freedom to experiment too. And you don't have to focus everything on one spot in the body and in one region of anatomy, but it's really that whole picture and that whole functional idea of the body that we can draw into our classes and our inspiration there.
You had one study in here too that I hadn't seen yet that I really liked, called the role of fascia in non-specific lower back pain. One with Carlos Deco again. And what I thought was really interesting as an acupuncturist, especially, was that they were using points just on the legs and the arms to treat the thoracolumbar fascia, and I think they were measuring changes in the thoracolumbar fascia, if I remember correctly. And a lot of them actually overlapped with very familiar points I see from an acupuncture perspective, and points that would more traditionally be used for lower back pain as well. So it was really interesting to look at some of those. Some of them are kind of hard to see in the pictures exactly where they are, but I thought that was really interesting to be able to go and actually measure, because a lot of people do theorize that the meridians are in living in the fascia, and without going into a longer discussion on meridians, we actually have different layers of meridians, but the meridians that we know where the acupuncture points are, the ones that we can intervene with, are traditionally found on in that layer between the skin and the muscle. And so it's really interesting. Who knows? Maybe we know that there's this electricity, piezoelectricity in the fascial layer. Maybe there's something about that, with the acupuncture. I know I'm getting off on a tangent here with acupuncture, but it's interesting to see this from a fascial connection, fascial perspective, in a research study, really quantifying and looking at the changes in that thoracolumbar fascia as it relates to some of those points on the arms and the legs.
Really cool. I didn't know. Obviously, I'm not an acupuncturist, but so fascinating when those disciplines overlap. I love that.
I agree. Anything else on the tension system before we sum it up?
I
I,
think we're good here. I think we got that idea across.
yeah, and all of these can be longer discussions, but it's nice to be able to kind of look at the big picture. And then, lastly, just really briefly, just a side note that there is obviously a lot more that goes into this, things like lifestyle and mindset, psychology, tissue health. Did you want to make a quick note on that as well?
Yeah, quick note on a really recent study or paper, also from the group around Paul Hodges. And those of you who are interested in fascia or also in low back pain research, you may have heard his name. And that paper that we're again putting into the notes as well just puts out there this interconnection between our lifestyle factors, psychology, and then our tissue health, which can have an influence on fibrosis, on pain. So, as you say, we have sleep, we have diet, we have exercise, we may smoke or not smoke. We may have stress from work, from financial burdens in our family, and all of these things potentially can have an influence on our inflammation system, so systemic inflammation or local inflammation, potentially. And then those inflammatory processes, and we've kind of like referenced a little bit or talked a little bit about inflammatory processes today. It's a lot more complex, could be a whole podcast episode or even a whole training, I guess. But those inflammatory processes can affect our tissues, our fascial tissues, so much, and can create fibrosis, maybe local inflammation, even more so than systemic inflammation. And this can influence our pain experience so much. So it's really hard to measure the complex interconnections of all of this, but it's being talked about, it's being formulated as hypotheses in the research world that sleep loss or drinking alcohol or lack of exercise or stress do really correlate with fibrosis, with tissue health, and then potentially, of course, also following that with pain. And it's just, I want to end with that, or want to talk about that to end with, because it's so complex, and we've discussed anatomy and physiology of fascia and pain today, but it's just like one piece of that puzzle, and it's so much more complex, and there are so many different wheels we can turn. And we said it before, I'm very excited to listen maybe to this episode in 10 years, or redo this episode in 10 years, and hopefully we'll have understood so much more about all of these interconnections. And that is just really something that's probably in the books for the next couple of years to find more about these interconnections as they relate to our lives, and not just to the more medical aspects of the anatomy and physiology out there.
Well, and I think it's one of the many reasons why we do this show, why we run our trainings, why I love educating people, little tidbits of education in our classes on yoga medicine online, is because no doctor can have all the information, can look at all the things, can see all the different aspects of your health. It's impossible. So, if you end up in the if you end up with the right in the right place at the right time, maybe your health journey is a very quick and short one. Hopefully, I wish that for everyone. But for most of us, at some point in our lives, we have some sort, whether it's pain or not, some sort of medical issue where we might need to go through a few different practitioners. And I think um, one of the important things when we talk about, and I kind of mentioned this a little earlier in the episode, is that when it comes to health and wellness, I think it's so important to be, you are your own best advocate. And we really have to be proactive. We have to be, looking and experimenting and finding things that are helpful. And this is where I think all this podcasts and online information can be such a great resource. And beyond that, I feel yoga is such an important foundation for all of that because it gives us the body awareness to have the feedback, to know what's helping and what's not. Now, there are some instances where, we might not be able to always subjectively discern everything, but for the most part, our body and our fascia is brilliant. And hopefully you'll get that from this podcast too, is it's constantly listening, it's constantly adjusting, it's constantly responding and adapting and protecting. And sometimes it needs a little push or a little grabbing the steering wheel and steering it in a different direction, which you can see we have the opportunity to do in many different ways. But I hope that you'll go to sleep tonight and remember that this system, like all the other systems in the body, is brilliant. It really is. And the more we do with research, the more we really start to recognize how precious and brilliant this tissue is. It's not an inert substance, it's not an inert filler, but it's alive, it's listening, it's adapting, it's responding, whether you're an athlete, to physical demands or to stress demands or to inflammation or to many other things. And that's kind of, I think, this last little section about lifestyle kind of summarizes is that everything else is influencing it. Not only is the fascia influencing everything else, but everything else is also influencing the fascia. We are an interconnected system. So, and I think it's an important thing to have an appreciation for that. Not only does everything we do matter, like the moment you get up and move around, or the glass of water you remember to drink, or the vegetables that you eat, everything matters. And that doesn't necessarily mean that we need to live in a bubble and do everything perfectly. But even if you're just able to do one healthy thing for yourself, just that one thing is so important because it's shifting that internal chemistry, that internal environment, and having a very real impact. And then if you do that the next day too, and the next day, right? So find the simple things, make it part of your routine, know that the system has your back, that it's brilliant, and maybe even tuning into it in your mat in those moments in shavasana or those moments between poses, sensing into this layer between the skin and the muscle, and feeling into its brilliance so that you can feel it and experience it yourself.
Yeah,
Do you
I
have
think
any?
you put it,
Yeah.
yeah, I just want to say you put it beautifully. And I do hope that our conversations just get across that we don't think that fascia is the only actor on the stage, but it's anything but the underdog. And it's just a fascinating tissue. But you just put all that beautifully, how that relates to our lives. So thanks for that.
Well, thank you. And thank you for bringing all this fantastic research. We'll have links in the show notes for you guys who are research nerds who want to dig through that, but hopefully that gives you a nice overview of a lot of information. And I'm sure many more fun discussions to come. We love your feedback. You can always plant ideas in our heads if you like, anywhere you like, commenting. And we look forward to the next discussion. Thank you so much, Katja. It was so nice to have you.
Till next time.
Thanks for listening to Yoga Medicine. If you like the show, please be sure to subscribe and leave a rating and review on Apple Podcasts or wherever you listen to podcasts. And if you got something out of this episode, please spread the word and share it with a friend. You can find more information, articles, trainings, and classes at yogamedicine.com, or check us out on social media as Yoga Medicine. You can also email us at info@yogamedicine.com. Thank you for being a part of our Yoga Medicine community. We look forward to seeing you again. The content of this podcast is not medical advice and is not meant to replace medical care. Please consult your healthcare provider to determine what is best for your unique healthcare needs.